Hello again. I'm here with you again to discuss about acute change of condition in nursing home, and that will be the part 2 of what we discuss. As we discussed as of today, we're going to have a series of the short videos that will discuss about the second part of our topic, which is going to be assessment. Now, the first thing that we learned from the last time is recognition of acute change of condition. We understood that it is very important to know what does it mean with change of condition. For example, if the patient is not the baseline or the patient is acutely changed from what it was before, this is so important that we know, is this the acute change of condition or no, this is really a chronic problem and is not really changed from the baseline. We talk about mental status, we talk about different scenarios that can explain how we can say this is an acute change of condition. One of the things that is so important is descriptions of the symptoms and definitely a documentation that we do. We talk about it. Like, for example, when somebody is having tremor, it doesn't mean that person has seizure. Or somebody has only have chills, doesn't mean that person has a seizure. If somebody has fatigue, it doesn't mean that person has motor weakness. That's very different. We have to have a good description of what we talk. Like, for example, we can say patient is not able to perform ADLs, which was able to do before. Or definitely there's a change in the respiratory pattern from what I've seen in the past. These are what we discuss, acute description, and that's very, very helpful when we describe to the patient, to the attending physician. The other part that was very vital, and we're going to talk a little bit more in details when we learn about assessment, is communication between the staff. Who is responsible? Who is the first person to recognize acute of change of condition? There should be a series of conversation that is going to happen between them. Who's going to be reporting to who's going to be in charge of getting the key information from the chart, who's going to prepare the telephone encounter or even texting encounter, whatever we use it in our facility and you like it, that can be very, very helpful for you to understand who's responsible for for what, and who needs to report to these things to somebody else. And the next thing that we talk about, communication with attending physician. This is very important, how to describe symptoms in a telephone encounter. When you pick up the phone or you want to do the texting, messaging, like people do Tiger Text today in our facilities, or the people do the text messaging, it is so important that we put a right information. We talk about it in the part 1. I encourage you, if you haven't, if you wanted to remember again, just go back and again watch the part 1 again. It's so important to talk about quality of the symptoms, onset of the symptoms, what makes it better, what makes it worse, how the symptoms is. You can describe what happened with the symptoms in the past. Patient had the symptoms exactly similar, and this is what had happened. We transfer patient to emergency room. They just did some IV fluid. Patient got better. Is it a lot of things? A lot of information can be helpful, and this is exactly what we talk. Find the critical information. The critical information can be exactly related to the current symptoms that you're discussing, or maybe it's some sort of the information that is very relevant in the medical patient's chart. Like, for example, if you use electronic system, like we use PCC in our facilities, or overall point-click care, but any electronic medical record or anything from the hospital, discharge summary, labs from the hospital, labs that you've done for the last week, this all needs to be discussed. There all needs to be to pull it off, and we prepare that for acute change of condition, because that can be very helpful. Like, for example, if patient had hemoglobin of 7.5 yesterday, and today you notice that patient has shortness of breath, that piece of information is going to be extremely critical for clinical judgment for you and also for attending physician to really have a better idea what we are going to cover right now. The most important part of anything in a skilled nursing home, when we talk about recognize, assessment, treatment, and monitoring. Now, assessment is the key, and we are going to have a series of assessment based on step-by-step symptoms related, and we'll talk about the symptoms, how we do assessment. Because when you learn assessment, you're able to learn everything related to recognizing the symptoms, maybe differential diagnosis in your brain, and also how to communicate it with the attending physician in the facility. That's going to be the key of information that you needed. Again, there's a 3-part that is so important when we talk about steps in any assessment. Observation, which is going to be objective, interview, you ask the question, and examination. These 3 things is a part of all assessment that we're going to do. For every single residence in a skilled nursing home, whenever there's acute change of condition, these 3 keys is so important. What is your observation? We'll talk about it. And what is the interview that you're going to ask the questions? And what is your finding as examination? Examination can be palpation, can be touching, can just check the vital signs. All of them can be part of examination. We will talk about it more later, even for regarding the examination. The first thing is for observation is the level of the consciousness. That's a very, very important. Is this patient alert or confused or disoriented? This is so important. That can be a key for the first step of observation. Mr. Smith or Mrs. Smith always been an alert person. She or he was talkative, able to communicate very well. But my shift when I started, this person is different. Is definitely more confused. When I ask him directly questions, which is going to be part of the interview, which we're going to talk about it, it's very important that he doesn't know, she doesn't know where he is or where she is. That's the key. That means definitely there's something internally going on, either in central nervous system or metabolic or something that we're going to figure out what's wrong with that. What about general appearance? Is it important? Very important. Especially for residents that always been kind of like very good on cleaning themselves, grooming themselves, but it's not the case today. I see all the foods in the clothes, very dirty. That's kind of unusual. If you have a long-term patient and the person is always shaving every day, very clean, but you see for 1 or 2 days, that's not the case. That means definitely something is going on wrong, and we have to find what's going on. As your patient's speech is clear, is it exactly the speech you're expecting? If you don't know the patient and you see the patient, the speech is not clear. When he speaks, you don't understand. The words, the way that communicate through the speech is not clear. Always go check the chart to see what is the baseline of the patient. Or if you have any colleagues or any CNAs and say, can you come and help me? This is my first time that actually I see this resident. Is this the way that he or she's talking? Is it her or his baseline? Is that the way always that person talking? That can be your point, that this is the abnormal speech or this is the normal speech. The most important part is the skin. The skin is actually tell you a lot of things. The skin, it's the change in the color of the skin. Is it very pale? Is it yellow, which is more jaundice? Is something that's going on with liver? Or if you see a lot of bruises in the skin, these are very tricky. You see a significant erythema or redness in the skin. Maybe it's underlying infection or a broken bone is there. The skin it's the best way that the patient is talking to you. Especially for the patient that not verbal, the skin is always the key. Make sure anytime when you have acute change of condition, do not hesitate to open up the gown of the patient and looking for the skin. The skin is talking to you and has a lot of information for you that you can kind of contribute to what's going on. You can easily find dehydration from the skin. If the skin turgor it's not very good, then you know that the patient has definitely dehydration. A lot of things is going on with the skin that you can see. Rashes. You have a diffuse rash all over the skin. Somebody has fever. Somebody is confused and you open up the gown and see the rash all over the body. That means we're dealing with a systemic inflammation. Can be infection, can be side effect to medication, can be many other things, but that should be addressed ASAP. That's why skin is so important. And again, then you do an observation. You don't need to put your stethoscope on the chest. Even when you're close to the patient, you can hear wheezing. You can hear the patient gargling. Especially that can be very helpful. Maybe you have a trach patients in the floor, and then you kind of talk next to the patient. The patient wheezing sounds is just very visible. When I walk to the room, I can hear that. This means that you're dealing with probably some sort of obstructive things, or the gargling, which is more upper respiratory problem. How's the patient face look like? That's very important. It's just the patient face, the skin of the face, as we discussed, is to look pale, sad, agitated. I mean, the face can talk to you a lot, and that can be part of your report. Doctor, I went to the room and I see the face of the patient. Doesn't look good. This is what I observe. The skin is changed. The patient is kind of like having a very strange face looking at me. I couldn't get the gaze on the eyes. For example, I see asymmetry in the face of the patient. It's a lot of things you can find in the face. Is your patient respond? And that's going to go to next step, which is your questions. When you have appropriate response with that. Don't forget, for many of the patients that you have in a skilled nursing home, there's three things before you asking any question is very vital. Is your patient able to hear? Is your patient need to have eyeglasses? Is your patient in a comfortable situation? These are first thing you need to check. There is a reason. Most of the seniors that they're living in the nursing home, they do not hear very well. They have sensory hearing loss, and this is why they have a problem with hearing. Many of them, they can't see you. They have macular degeneration, they have a severe cataract, and they just, when you come to their bed and they cannot see you, or they have only a problem with the central vision or peripheral vision, and you just be on the side of the bed, they can't see you because they only see the central. No, if you start to yelling and shouting on them as, hey sir, how are you doing? You just make them more nervous, more agitated. You need to understand this patient has a vision problem. You exactly come to the side that patient can see you. If the patient needs eyeglasses, put it on. And the other thing is a comfortable position. A lot of patients, they're in an awkward position, it causing pain. At the same time, you want to do your assessment. That doesn't work. Patient's going to yell, going to scream, and is going to be very unhappy with you. It's so important we talk about elements in physical examination, which is so important that we discussed in the past. Vital signs are the first element in your assessment. We're going to talk for some days about assessment. Again, we talk about the status of the hearing and vision, which is so important, and the skin, as we discussed, looking for entire skin, edema or any erythema is going on. What about ADLs? ADLs is part of your physical examination in a skilled nursing home. Is the patient able to do his or her basic things that she was or he was doing in the past? Pain is part of the elements in your physical examination. When I move the hand, it's hurting a lot. When I just palpate the knee, it hurts a lot. That's part of your physical examination when you do palpation. Then pain is part of your physical examination. And again, always auscultation to the heart and chest. Definitely listen to abdominal area to see if you have bowel sounds. If the bowel sounds is active, if you do not hear anything, somebody has very distended belly, you put your stethoscope on the belly, you can't hear anything, that means that you have a lot of problem. It means that we have obstruction problem there. Palpation of the chest wall, somebody says my chest is hurt, and you palpate and say, ow, it's a lot of pain here. That means that definitely a lot of musculoskeletal pain involved. It's not necessary. I'm not saying 100%, but less likely is cardiac. It's more chest wall pain. And palpation of abdominal area, somebody says I have pain, go ahead, have your hand first, listen to the belly, and then put your hand on the belly, and you can see, is it distended, it's very, very rigid, or we're going to talk about abdominal pain in the next series, or very tender in touch. And again, definitely any painful area, somebody has leg pain, go ahead, touch it. See the skin, touch the area, and see if the pain is getting worse with your palpation. Can be very helpful for you. Well, when you talk about vital signs, there are some elements in vital signs that we talk. Heart rate, blood pressure, respiratory rate, O2 saturation, temperature, and pain. Today, we only talk about heart rate, and we're going to stop our video today. First thing about heart rate, you need to understand the heart rate is a normal heart rate is 60 to 100 per minute. Now, let's see where the heart rate is going to stop. We have two generators here in the heart. One of them is sinusoatrial node, and atrioventricular node is here. There are two generators here. This is the main one. Sinusoatrial is the main one, producing electricity to the heart and sending to the AV node. And from AV node all the way, we have the bundles of the his going to the ventricle. And this is the way the heart in normal situation, we have 60 to 100 times per minute that we have this situation, the heart rate. If we have anything above 100, we call tachycardia. If we have anything below 60, we call bradycardia. But it's very important, what are the cause of tachycardia? Technically, by conventional tradition, tachycardia requires the heart rate to be greater than 100 beats per minute. But that can be absolutely normal. But for example, when you do exercise, or it's a physiologic response, you should have elevated heart rate because your sympathetic nerves going to be activated, your heart rate needs to be increased. Or when you have a fearful situation, you're scared of something, your heart rate should goes up. Or you go see your boss today, or you see your supervisor today, definitely your heart rate is going to go up. Or you have a very serious conversation. The normal heart rate is technically as a result of complex interplay between sympathetic nerve and parasympathetic nervous system. And this is why it's what we call the normal heart rate. Now, normal heart rate can be very different. Like in the small kids, like babies, especially infants, heart rate is between 110 to 150 beats. They have a very fast heart rate because they need a lot of circulation because the nervous systems are developing so fast. And then gradually, within the next 6 years of our life, our heart rate goes down to make it to 60 to 100. Because most of the time, our heart rate, or technically, it's technically normal would be 65 to 85, which is it's going to be slower in older age. Don't forget that, that can be the loss of variation in the normal heart rate. But when we talk about a disease problem, definitely something inflammatory. When we have fever, when we have dehydration, what we call a volume depletion here, this is going to be a situation what we call sepsis. Having some fever, we have a lot of inflammatory. Very, very important. When we have anemia, we have definitely this problem as the elevated heart rate. We have pulmonary embolism, which is one of the other situations that we have PE. It can increase. Anxiety, I said, it can elevate the heart rate. Thyroid disease, especially when it's hyperthyroided. When we have heart failure problem, especially decompensated, or heart going to be faster in order to compensate, that's a very normal response, which shouldn't be normal because that makes the situation worse. When we have any time hypoxia, oxygen goes down, somebody has asthma, COPD, pneumonia, oxygen goes down, heart rate's going faster in order to compensate, making more blood circulation. Pain always causing heart rate goes up. Medications, we'll talk about it. A lot of illicit drugs can cause the heart rate going faster. People smoking marijuana, using marijuana, or cocaine or amphetamine based, that can cause that. And myocardial infarction always as one of the source of the problem, causing elevated heart rate. Let's just review some scenarios about the tachycardia. A patient has, with the breathing treatment, as I said, the medication. The number one medication that we use a lot in the nursing home is a breathing treatment. Duoneb, albuterol. They can increase the heart rate. That's important because when you have a patient that you have a breathing treatment and the heart rate goes fast, you don't need to panicking. You just need to wait in order to calling the doctors at 2 o'clock. Oh my God, the patient heart rate just goes 110 right now. This patient is not symptomatic, but I just gave the breathing treatment half an hour ago. Boom, that's the cause. The heart rate can goes up because these medications, there are what we call beta agonists. They can stimulate the SA node and they can make the heart to make more electricity. A patient with worsening of pain in your shift, that can goes up the heart rate. That means when you have some scenario tachycardia, the pain is causing heart rate to goes up. You don't need to call 911 because the heart rate is 110. You just need to say, okay, the patient's pain has got worse and heart rate goes faster. A patient had multiple episodes of vomiting. What is that? Dehydration, volume depletion. And that can tell you that, okay, well, it reported last night patient had vomiting, this morning had vomiting, noon he had vomiting, and now in my shift at night, patient has very elevated heart rate. I know the answer. That the problem is because of volume depletion. And that's going to be another scenario. That similar scenario, a patient who is demented is not able to eat and drink, is volumely depleted. That's why the heart rate can go faster. A patient looks pale. I told you, skin is always the key. Who looks pale? Somebody has anemia. Is it anemia because the hemoglobin is dropping? Somewhere is bleeding, or patient doesn't take enough iron, or is losing iron somewhere. It's internal bleedings, maybe something going on, or the patient is not eating very well. There's many scenarios going on, or maybe related to the disease. But looking at skin pale and the heart rate is elevated, they're both connected to each other. A patient who has desaturation and shortness of breath, we talk hypoxia, that causing heart rate to go faster. A patient is ongoing worsening chest pain, myocardial infarction, ischemia, that can cause your heart rate to be fast. A patient has a temperature high and very lethargic, feverish, that means the patient is septic. A patient with history of mental issues with uncontrolled anxiety, that patient is also another patient that can cause this problem, is uncontrolled anxiety. Now, concerning time about heart rate is a different scenario. Number one is always check the baseline of your heart rate. Is the rhythm is changing or the rate is changing from the baseline? That can help you. Always look at the previous vital signs and see what is the baseline heart rate. Is always beating 93, now is 98 or 101, should be concerning? Probably not. But somebody's always been like 61, 62, 65, and tonight is 102, 103, 121, 120. That's concerning. That means it definitely a significant shift. And anytime heart rate about 120 should be reported. That's something that we need to know. But if what about 100, like somebody has 102, 100, should I report that? Probably not. You just can address it to the next shift. But if the patient is symptomatic, chest pain, dizziness, volume depletion, and many other symptoms, then yes, you need to report it quickly. The rate, the pattern of the heart rate is also important. Is it regular or irregular? It's not important for you, but sometimes when you check the pulse of the patient, you see is it regular fast or is it irregular fast? It has like couple beats and then 3 or 4 or 5 beats and then a slow again. It's very irregular. That's probably more arrhythmia, like fibrillation or flutter. But you're not in charge in nursing home to diagnose fibrillation. This is the job of the physician to diagnose. Probably the best way is to EKG. But most of the time we don't have the services in a skilled nursing home. But it's nice if you palpate the pulse sometime and see if it's regular or irregular. That can help you a lot. Bradycardia on the other side is a heart rate less than 60. Usually between 55 to 60, patient doesn't need to be reported because it's just if it's a significant shift from the baseline, yes. But that's different. Like always the heart rate was 85, but tonight is 51. That means a significant bradycardia. That needs to be reported. But most of the time, the only time you need to report when the heart rate is slow heart rate associated with symptoms. Fainting, lightheadedness, have a fall, feeling dizzy, a balance problem. These are the main symptoms related to bradycardia. Now, when we talk about bradycardia, the bradycardia, what is normal in bradycardia, what is abnormal in bradycardia? Normal in bradycardia is well-conditioned athletes. But most of the athletes, especially especially the running or runners, they can have at the sleep time a very slow heart rate, which is very healthy. But a lot of time, or the patients, sometime in some of the endurance activity, we can see this pattern. But an abnormal is the many reasons. Some people, they have a problem with SA node, that they have dysfunction. These are the people usually ended up to having pacemaker. But a lot of time medications can cause that. Medications is like beta blocker. Beta blocker is a medication we use for blood pressure or controlling the heart rate, like fibrillation, like metoprolol, atenolol, carvedilol, or calcium channel blocker, like verapamil, diltiazem. Amiodarone is lowering the heart rate. Narcotic, and especially the sedative medication like benzodiazepine, they can slow the heart rate. And there are the medications that we heavily use in a skilled nursing home. That's something we need to remember. Patients with a sleep apnea usually have, they can have a very severe bradycardia, even sometimes drop less than 30 during the apneic episode. That's why sleep apnea is one of them. Myocardial infarction, as I said, especially if it's affected right coronary, is one of the other things. A lot of people, they have exaggerated vagal activity. The vagal reflex is going to be activated. Like the people have carotid sinus stimulation. If you rub the carotid artery very strong and press it, it can slowing the heart rate. The people have a very, very tight collar, or they have a very tight tie. Sometimes they get syncope because it's pressing the carotid artery. People after cough, that's very important. Or people going to the bathroom and they have a very large bowel movement, or they press so hard, they have a hard stool, they have to press, they go to what we call vasovagal syncope, and they can have a slow heart rate. Some of them, they ended up with syncope and dropping in the bathroom. It happens a lot in a skilled nursing home environment. A lot of people, they can have hypothyroidism, especially when the TSH is high, thyroid is not functioning very well, heart rate goes down. And infection. Infection is not the one that you see in a skilled nursing home, because it's like Lyme disease, parasite infection, malaria, Rocky Mountain spotted fever. It's not the case for us, but technically these are the normal. Now, the last thing I wanted to talk is how to report the heart rate change in the telephone encounter when you talk to a doctor. First of all, what is the baseline heart rate of the patient? Last days and also at the time of admission. That can be a key when you pick up the phone and wanted to report the heart rate. What is the baseline? The next thing is heart rate associated with any change of symptoms. Do I see any symptoms? Patient has chest pain. If the heart rate goes down, dizziness, lightheaded, nausea, vomiting. That can be the key, because that's exactly going to be the key of judgment for transferring patient to the hospital. How many times have you checked the heart rate? Is it only one time that you check the heart rate is high? Or no, it has been checked during multiple times during the shift. Last shift also was high. We check it again today, not only based on one recording. What was your assessment so far? And that's going to be the key of the discussion. Any abnormalities beside of the heart rate? What about the blood pressure? Heart rate is high, blood pressure is low. Patient probably is septic, going to septic shock or something like that. Or could be myocardial infarction, and that is also a possibility. These are the very key. Or patient has hypoxia, saturation is going down, heart rate is going high. That can be the key for you. PE, pulmonary embolism, one of the diagnoses. Is the patient looks pale? Because you evaluate, you observe the patient as we discussed, and you see the patient is pale, means patient, the skin has anemia or something like that. This is one of my assessment. Any medication changed recently? Has any medication has been added? Any breathing treatment has been added? In the case of bradycardia, any new beta blocker, any new calcium channel blocker, any new heart medication, any new narcotic, any new sedative medication, these are your part of your assessment. In case of tachycardia, we talk about it. Any associated symptoms? Does the patient has pain, sweating, chest pain, vomiting, bleeding? That means that they're losing blood, has anemia, heart rate is fast, vomiting, dehydration causing that. And in the case of the bradycardia, more focused symptoms will be dizziness, will be fainting, fall, loss of balance, nausea. They can be good for that. And did we check with CNA about the fluid intake? We'll talk about it. volume depletion. Have we checked before we do the test? Yes, I check it, doctor. CNA told me patient hasn't been eating and drinking for the last 24 hours. Dehydration, tachycardia. That's very important. Or maybe there's a baseline infection. The doctor can make a judgment based on your things. And the last slide will be the key information. What is the patient's recent lab? I told you, before to have the telephone encounter, the key information should be pulled out. The recent lab, looking for CBC. I want to check hemoglobin, and I want to check in basic metabolic panel potassium, because the potassium change can cause arrhythmia, heart rate fast, heart rate low. I need to know. Any new abnormality. Is the patient had any recent TSH, if the patient is a bradycardia, or a patient is on thyroid medication? Maybe we're giving too much thyroid medication, make the patient hypothyroidism, and that's why it has the bradycardia. But usually that's going to take a long time. But it's good to know that patient is taking any thyroid medication. Is the patient on any beta blocker? Atenolol, metoprolol, carvedilol, propranolol, or calcium channel blocker, diltiazem, or verapamil? Or is in case of bradycardia, patient on any comfort medication? Like, for example, patients in hospice and patients taking tons of narcotic and sedative is something that we need to panic, or we need to worry about it, or this is something we expected. Atropine we use for drooling or narcotic. I wanted to stop here. If to please email me for questions. There's going to be some questions for you, but these are basically the discussion we have for just observation, interview, examination, and now we started with vital sign. We will back again on examination and observation more. Thank you so much for being with me. Appreciate it.